Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'm joined by Dr. Adam Jaffe as we answer some lingering questions for hospitalists. Is the DOAC wars over? Is there a definitive right answer for oral anticoagulation? And who actually benefits from steroids when treating pneumonia? Well, Dr. Jaffe, thank you so much for being with me here today.
My friend, it is such a pleasure. I'm just so happy to be included and really proud of what you're doing. I think it's really awesome.
Well, I'm giddy. And for the audience, Dr. Adam Jaffe is a clinical hospitalist. He works at the University of Alabama Birmingham Medical Center. He is, I believe, an assistant professor of medicine. Is that correct? Yes,
That's
he
right.
is. And a very down-to-earth but excellent clinician and a great friend and a great buddy. And I'm just giddy to have you here with me today.
Well, you're too kind. The pleasure is mine, really.
Anything else you think that the audience needs to know about you?
Oh gosh, where to begin? We could do a whole show on just this, but yeah, became friends with Mason and his amazing wife Anne several years ago now. I mean, I think just looking back, thinking like how long ago that was.
I know. Yeah.
But it just kind of had me recapping our friendship and I think some interesting facts about me. Big pickleball guy. So when you and Anne make it back down here to Birmingham, bring some paddles. I'm gonna get you out there and playing. And then I was also trying to think about other interesting things. So your wedding was my first time in Arizona, and you and Anne introduced me to what I think is one of the most magical creatures, the javelina. I was recently back in Arizona last year with my best friend from med school, Ariella, shout out to her. And we were in Sedona, so not Tucson, but I saw this guy and was like,
That is
I've got to have it.
fantastic.
So it's just an extraordinary creature. If you haven't heard of it, I hadn't heard of it. It's just kind of a mess of characteristics, but special.
Yeah, I'm like, is it a mythical creature or is it real?
Right?
I've never seen one. Did I tell you the story? I'm sure we talked about it. In fact, I remember we took the same flight home, if I recall. I think I remember sitting next to you in the airport. But my dad was driving my rental car back from the wedding, and the wedding was a little ways out of town, and going, desert road, going straight down, going God knows how fast in the dark. And then bang, he did a significant amount of damage to that car and like crushed a javelina that he never even saw. We assume it was a javelina. Anne's very
Yeah.
skeptical. Anne's like,
It was
it was
definitely
something
javelina.
else. Yeah, man. Very cool. And so, for the listeners, when I reached out to Dr. Jaffe about coming on on Inpatient Update, he was like, "Oh gosh, of course. I've been listening since day one. I'm already saving lives on all of the practice-changing
That's
evidence
right.
you've given me in your show. I've just been waiting for your phone call." True story.
Absolutely. I've got the text to prove it somewhere.
No, but very gracious to be on the show. As he said, Adam and I go back to residency and we were in the trenches together. And so really grateful to have him and excited for our discussion today. So Dr. Jaffe, tell me, how often do you start a patient on oral anticoagulation?
It seems like it happens all the time, like blood
Yeah.
clots, AFib. It you see it all the time in the hospital, especially new starts, which I think you asked new starts specifically. But
Yep.
yeah, this is something that we are seeing if I'm on service, for a week, multiple times. And whether
Yeah.
it's, they come in with the symptoms of, a blood clot, or we just happen to find evidence of AFib on an EKG or find incidental PTE. It's just a part of life. There's no getting around it.
Yeah. Agreed. I'd say if I'm on service for a week, I mean, it feels like on average twice a week I'm starting anticoagulation. I don't know. I mean, this is all vibes, but it feels like at least once a week on service. I'm brand new starting anticoagulation for someone. Um, when you start someone on anticoagulation, do you have a go-to? Do you have a forever and always, or do you
Yeah.
mix it up?
No, I'm an Eliquis stan. It's
Yeah, same
I
here.
think I think a lot of us are, and it's kind of like you said, it's just been on the vibe. I feel like there's been this thought that it's the superior choice, but it had never really been tested until recently, which we'll talk about here in a minute.
Mhm.
But that's kind of the go-to. Insurance, sometimes does prohibit that. And then you look at an alternative like Xarelto, and you still feel pretty good about it. I mean, there are worse drugs like warfarin, which is just
Right.
horrible that we still have
Yeah,
people
see,
on it.
unlike the drugs we're talking about, I do feel like it's a personal mission that anyone who's on warfarin, unless they have fantastic reason like APLS or something, like get them off of it. That's
Yeah,
I'm trying, but the 70-something-year-old gentleman and his I just I like my warfarin. I like my
right.
Coumadin.
That's right. They love going to clinic. It's a little social visit to
Yes.
get their INR checked. And I'm like, babe, join me at pickleball. It's like you can totally hang and not have to deal with this horrible drug that just messes everything up. There's a better way.
Yeah. Yeah, totally. Um, so yeah, I'm similarly always Eliquis, always Apixaban. Really, if I'm ever not picking, and I mean, for me, that's just mostly habit and practice pattern from, it seemed like that was the culture at UAB. I know it's the culture where I work now. Seems like it's generally the culture at least among hospital medicine. But like you, if there's an insurance issue is the biggest reason I'm picking rivaroxaban instead. I saw it as like a coin flip, and I don't know, and it is attractive, the idea that you do a 1 time a day anticoagulation instead of a 2 time a day med, which I probably honestly should have been thinking about it and pushing for it more, but I'm just clinically comfortable with apixaban, and so that's what I do. That's what I would do for me just because 'cause I've seen it enough, I have the reps enough, seen enough patients on it. But for me, I thought of it as like a coin flip, and so it was good and interesting to see this recent trial that came out. And this was an article that was in the New England Journal of Medicine just this year, 2026, and it was bleeding risk apixaban versus rivaroxaban in acute venous thromboembolism. And so this is our first direct head-to-head randomized controlled trial. Let's, let's slam down, let's settle it once and for all. Let's figure out which one of these is better. And what they were specifically looking at was which one of these is more likely to give you a clinically significant bleeding event. So this was like I said, randomized trial. The N was 2,760. They looked specifically at folks with clots. They actually excluded anyone who needed anticoagulation for a different reason. They also excluded folks with active cancer, folks who weighed greater than 120 kgs. But they followed for 3 months. And like I said, the primary outcome they were looking at was clinically significant bleeding. And then they had some secondary outcomes like major bleeding and recurrent clot. And the headline takeaway is for Pixaban, the clinically significant bleeding was significantly less. There was a 54% relative risk reduction doing Apixaban instead of rivaroxaban for their primary outcome. And so that gave us a number needed to treat of 27. And then major bleeding they looked at, there was also less likely in the Apixaban group, from it was 0.4% versus 2.4%. So even more impressive. And then importantly, the other stuff they looked at, there was no difference. So specifically, the recurrence of clots, the recurrence of venous thromboembolisms were essentially exactly the same between the two meds. Death ended up being the same. So essentially, the take-home point for me being bleeding less than Apixaban versus rivaroxaban, um, and clots the same. And so for me, I'm saying, great. This reaffirms what I was already doing just based on practice pattern. Um, but it certainly makes it so that going forward, I'm going to be even more firm on that. Um, what are your thoughts and takeaways on this?
Yeah, totally agree. I mean, this is something that we have been, I think, thirsting for, right?
Mm-hmm.
Like to finally know, like it's one thing to be going on vibes for all this time and to have these other studies where they're compared to a warfarin and it's kind of like, well, we think that apixaban is the superior choice, but to put them head to head finally and have a sense, and to confirm that what you've been doing is right is always, we love that. But to kind of, yeah, put these two, uh, how I was going to phrase it was these heated rivals, if you will, and to kind of pit them against one another and see which one comes out on top. Um, I know Connor and Hudson are out there listening to the podcast, so I just had to put that out there for them. We're finding out which one is the right choice for you guys. It's Apixaban.
Today's episode brought to you by Apixaban and Heated Rivalry.
Right.
um,
Some a couple things with the study I will say. Majority white, I think
mhm.
90%. Um, the length of follow up was only 3 months, so who knows if there's something out there longer. I'm sure that'll be investigated at some point. The other thing that I saw kind of just digging through the article was that there was a little bit of variability in compliance with
Mhm.
the medicine. So the apixaban group was, I think, 65%, whereas the rivaroxaban was 75%. So that kind of makes you wonder, like, was there a bleeding difference because more people were taking the drug? And if you're not taking the drug, yeah, you're probably not going to bleed. So that was, an interesting, they mentioned it, but didn't really go too into it. And then I don't know if you can show that graph, but the Kaplan-Meier graph that kind of showed, if you open the article, there's a Kaplan-Meier graph kind of towards the end, and it shows um, there's a kind of a difference more in the beginning during the loading phase
Mhm.
of the drug. And I honestly had forgotten about the loading phase of Xarelto because, again, I never prescribe it.
Right.
But you forget that it's a 21-day load as opposed to a week. And really, after that load, the the bar graph, the line kind of started following the same trajectory. So it really seems like that loading phase is
Yep.
maybe where the danger zone is for a bleed. Again, I think both are probably great drugs. It's really interesting and awesome that they're finally being compared, but we're still going to do what we've been doing. But those were
Right.
just a few little things.
Yeah. Yeah. I noticed similar things. I will ask you though and mention. So I went to SHM Converge, and in one of the talks, I think it was the anticoagulation talk I went to. They mentioned this trial and they threw up the meme of this kind of broy looking guy squatting over a grave, doing a little peace out sign. You know what I'm talking about? You know the one? And then
Yes, yes.
on the headstone they
Oh,
put Xarelto, and
yeah.
the guy squatting on the grave was a Apixaban, saying like, "This is done, it's over." So what do you think? Do you think the war is totally over? Uh, do you think you'll ever prescribe rivaroxaban again?
Rivaroxaban, it's probably, I would say it's on like a couple pressers. We're doing some goals of care conversations about rivaroxaban. But I'm grateful that it's there if I do need it because insurance is an issue.
Mhm.
I think I would still tell people like this is a great drug. Um, and, a once a day. So there are, like you said, some benefits to it. So, um, yeah, I mean, it's an L for
Yeah.
rivaroxaban for sure.
Yeah, agreed. And I'm with you on the caveat that it does seem like the problem and the difference is the loading. And so I don't know, maybe if they just need to, if the makers of rivaroxaban or whatever just need to sort of reassess their loading dose and the protocol for that, and maybe we see some of this even out and they, zombie and resurrect and get out of the
Right.
bed or climb out of that grave. Um, but I think my practice going forward will be similarly. I wasn't writing it much before, and I'm going to keep not writing it much unless something else gives me a good reason to. But I'll explicitly try to avoid it. Whereas before I was just like, I'm not even paying attention if whatever insurance, I don't care, whichever one. But now, I mean, I will try to start people on Apixaban instead because it's clearly just as good. And like you said, you mentioned the compliance, and obviously a 2 times a day medicine is going to have more likely have a compliance problem. Um, but but they had just as good rates, like exactly just basically of recurrence of clot. And now that obviously 3 months is like not an incredibly long time for us to follow up for a
Right.
clot. At the same time, if this is a provoked clot of some sort, that's as long as you would have been on anticoagulation. So um I won't be telling people to stop their rivaroxaban if they're off it because of your point that this difference is all that very first part. That's like the first 3 weeks or something. But I won't be starting anyone on it going forward.
Totally agree.
Okay. Any other thoughts, inputs, insights on the Cobra trial?
No, I love the name. We love a,
Right.
a fun name.
Oh yeah. No, a memorable name certainly helps me out.
Yeah.
Um, all right. Well, and we can edit this part out if you want to, but if we want to, but tell me, is the Jaffe rule still going strong?
Oh my God, yeah. I was worried this might come up. The Jaffe rule lives on somehow,
Great.
and uh, yeah, it's only grown. For your listeners
Yeah.
out
Can you tell
there,
our audience what the Jaffe
um,
rule is?
sure. So this started, I'll say, and has evolved for sure. But you get to pick one lab value a day that you're just like, no, that doesn't make sense. Clinically does not match what's going on in the room. And we're just gonna do close our eyes, cover our ears, and pretend like we didn't see it. And I'm not saying it applies to everything. Please don't Jaffe rule a staph bacteremia. The lawyers would not love that. But sometimes, that little bump in the white count, and you're like, we're
Oh
we're just
gosh,
gonna
white
ignore
counts.
that. Yeah, we don't care about that. So I put a name to this. It's something that we all do as clinicians, as a resident, and it's just stuck around. So other services will tell me, "Oh yeah, we Jaffe ruled that," and I'm like, "No, no, no, that is not for you. That is for the medicine residents only. The ER is banned from telling me that they've Jaffe ruled something. So uh, this is
Are
only
they
going to
still so
propagate
the
this further."
so people are hearing it, continuing to hear it, um, at your institution, at UAB at least, not from you. Residents are still talking about this between themselves.
Yeah, I'll get in an elevator and with some residents, just at the same time. We're not on the same team or working together or anything. And then they're like, "Oh, like the Jaffe rule, Dr. Jaffe?" And I'm like, "Oh my God. Uh
Oh,
yes, but also like, who are you?"
yeah, I love it.
No, it's
Um,
it's hilarious, kind of terrifying. Did not think I would leave, that sort of impression or mark on the program, but here we are, Mason. It's
Well,
fine.
if you knowing you and working with you and knowing you can be sarcastic, it like obviously it's presented as kind of a flippant, like just pick one number a day and ignore it. And which is like when you're a co-resident or an intern, hearing you kind of speak name to that, it's very relieving because you're just like overwhelmed by every single number and they can go down a rabbit hole. So it kind of relieves that. But like honestly, like it's a s- a kind of flippant way of saying like look at the whole patient, don't get bogged down on one thing. And so like we joke about it and there are times it shouldn't be used, but it really is a um the core there is something really valuable of like
Yeah,
how we think about medicine clinically.
it is. I think it's that art of medicine piece that
Mhm.
you can't define in a textbook. It's the gestalt thing that you only get with the reps. And I mean, I was doing the math the other day. This is year 5 of attending hood, and I think we're still
Mhm.
perfecting our craft. And that's the beauty of this job. Like 2 plus 2 is not always 4, and patients are just interesting. But yeah, that thing still lives.
Mhm. Yeah. Just about any time someone asks me, What are you thinking about that isolated white blood cell count elevation?" I just want to be like, I'm Jaffe ruling that. Uh, well, speaking of ignoring labs, we're going to transition to a different topic here, but there is a lab that comes out of this that I've generally ignored, but it turns out could maybe give us a lot of benefit in treating patients with pneumonia. So, if you, Dr. Jaffe, if you've got, let's say, a 54-year-old gentleman comes in who's got who comes in, he's on, say, the ED's put him on 4 liters. He's got respiratory symptoms, 4 liters nasal cannula. He's got respiratory symptoms. They do a chest x-ray. He's one of our few people who actually has a good low bar pneumonia. It's just pretty clear cut. They've
Okay.
obviously given him probably Rocephin and Azithro. They do a viral panel. We just dropped an episode where we talked about viral panels and whether or not you treat those with antibiotics. But you do a drop viral panel and it's negative. Are you giving that guy steroids?
No, and I'm really not thinking about it.
Yeah, same here. I'm
But now
totally
now
totally
you've got
same
my
bucket.
whole world flipped upside down.
I know I'm in 100% the same boat. Um, Yeah, not even on my radar to treat community acquired pneumonia with steroids. Is there ever a situation where you have or you are treating pneumonia with steroids?
I mean, I'm reaching back to our days in
Yep,
residency in the ICU
ICU. Yeah,
when
totally,
patients are critically ill. And then that's really when the discussion would come up. And even then, I mean, attending to attending, case to
totally.
case, there was kind of reasons to, reasons not to. Um, but outside of that, never really thinking about it.
Yeah, no,
It's
totally
been
agree.
years.
The I'm in the same bucket. Even in the ICU, I didn't feel like we did it routinely or a lot. But I felt like we did a lot of, like, eventually we're gonna call something like cryptogenic organizing pneumonia, we're treating that with steroids, or they've got COPD because so many people do, and then we're treating the COPD exacerbation, so you're getting steroids for that. The thinking back on this, and it didn't even I don't think of it as being pneumonia, but COVID. Were
Yeah,
y'all routinely doing steroids for COVID when they came in? Yeah.
absolutely.
So I
Yeah.
think our hospital policy was if they're most recently, and we haven't been seeing a lot recently, so I'm not as fresh on it as I was for a while. But I think we were, if they have an O2 requirement, was sort of when we triggered putting them on steroids.
That
So
was generally our management as well. As if you had an O2 requirement, for sure steroids, plus minus, some antiviral stuff. But that was a clear indication on our end for steroids.
So this wasn't on my radar until recently, and again, this article was kind of banging around at the SHM Converge conference some, and I did feel a little bit like embarrassed that like it wasn't even something I had thought about, and they're like, we're talking about like who is the right patient to start it in, and I was like, I didn't even know it was any of them, hardly. But I will say that our practice pattern pretty much matches with more or less with the guidelines that the only guideline recommendations we had were either from the Society of Critical Care Medicine said if it's severe, or the European Respiratory Society says if the patient's in shock. So kind of lining up with what we were doing, I don't think as much as for a minute I felt like we totally missed a boat on this one, no, we didn't really. I think it's been pretty gray. But there was a recent article out in the Lancet, corticosteroids in community-acquired pneumonia, individual patient data meta-analysis. And so this was a this was kind of a complicated meta-analysis. Um, with some nuances to the methods here that we'll focus on what we get out of this clinically and not dive into that too much, but an enormous meta-analysis from an N standpoint, 3,224 patients, 8 different randomized controlled trials looked at, and the big question was steroids versus placebo. Is there a mortality benefit, and if so, who is it in? And so the sort of the primary outcome they were looking at was is there a mortality benefit, but a lot of the point of the trial was doing a lot of this sort of a subgroup analysis ish thing of looking and seeing which is the patient that we're actually helping, because generally we haven't seen consistent mortality and mortality benefit in giving patients with community acquired pneumonia excuse me, not antibiotics, do give them antibiotics, if it's bacterial, but steroids. And so overall, the study did find some mortality benefit, at 30-day mortality in treating patients with steroids versus not, with an absolute risk reduction of 2.2%. And that was a number needed to treat of 46. But when they broke down the numbers a little bit more, what was really exciting and what was that lab I was referring to that I pretty much ignore, um, I mean, if there's anything I'm the Jaffe rule, a CRP is often going to be it. But what they specifically looked at is for a C-reactive protein of greater than 204, um, was there a mortality benefit? And there was a significant mortality benefit, with an absolute risk reduction of about 7%, from 13% to 6%, and then a number needed to treat of 14. And then when they looked at less than 204 CRP, no mortality benefit anymore, it disappeared. But when these guidelines said severe pneumonia is what we should be treating, but when they looked at pneumonia severity index scores, if it was a 4 to 5, no mortality benefit when compared to if you're treating less than that. So the severity didn't seem to really determine whether or not the steroids conferred a mortality benefit, but the CRP sure did. Um, that's the big headline. A couple of just other odds and ends from the trial was in the treatment arm, there was statistically significant increase in hyperglycemia, which no surprise there. You're giving someone steroids, their sugar's going up. And also an increase in readmissions, um, which was also statistically significant, 7 versus 3.7%. Um, and so those were the big things. Um, What are your thoughts on this? Are you convinced? Is this changing your practice? What are you thinking, Dr. Jaffe?
Yeah, this one's tricky for me, for
Mhm.
sure. I had to chew on this one quite a bit, and I think more work needs to be done. There was an exciting article, I think it's a couple years old now, the Cape Cod, which looked
Mhm.
more at the like very seriously ill, high flow, intubation, things like that. So they were kind of grading more on the severity of pneumonia and found indication for steroids. This one's more based on the CRP, which I like you Jaffe rule a CRP
Yeah.
frequently, probably more frequently than I'm starting folks on Eliquis in a week. Um, but yeah, it's I'm torn because I think it's really interesting. And the studies, anytime you're putting all these different studies together, like when did they collect the CRP? There was a difference in the studies, and uh, starting the steroids within 24 hours. Some were within the first, 72 or 96 hours. So trying to chew and digest all of this, I think maybe where I landed, and you can tell me if I'm crazy, is I think initially I would just have someone on antibiotics. And
Mhm.
if after that, we're kind of within that 24 hours, like they got admitted overnight, I see them in the morning and they don't look better. And I feel like they should be better. If I've got a CRP, if the ER or someone thought to order it and it's over 200 and I feel like they're teetering on ICU, I might think about it.
Yep.
Um, but outside of that, just to start them, I don't know. I hesitate on that.
Yeah. I I this was interesting, and the fact that they looked at the CRP was interesting because it's nice that it makes some pathophys sense and that why are we giving someone with pneumonia steroids? And that's to reduce inflammation, presumably. And so this is one time where an inflammatory marker is probably a pretty good marker of inflammation. Whereas the severity of the pneumonia is really not a very good marker of whether or not there's a significant inflammatory component to this that would respond well to steroids. And so I think you and I and many of us hospitalists, like inflammatory markers, we kind of roll our eyes at it, especially in someone like I'm treating them for an infection. I know they're infected. Like, why would I even care? And so it's one that I rarely use and rarely order unless someone else has told me to, whether it's for a rheumatologic thing or whether it's the ortho folks trying to determine whether or not the osteo is active or whatever. Um, so, but I think I will. I am impressed. This risk reduction, this number need to treat of 14, like how many pneumonias am I
Yep.
treating? How long does it take me to treat 14 pneumonias? And it's, oh, I don't know, a couple months maybe, probably less.
Yeah.
Though this is specifically within the cohort of folks who are it's a number needed to treat and the CRP greater than 200. I have no idea what the CRP usually is in my people with pneumonia because I don't
Right.
look at it and don't pay attention to the number ever, but certainly not in someone I already know has an infection and I'm treating. But I think I will. I'll get it. I'll, get the number and kind of go from there. But I do think I am generally in the same boat as you. If I don't see that someone's seeming particularly sick, then it's gonna be hard for me to justify it. Um, but I mean, this is a 30-day mortality benefit. Like, I like it when my patients don't die in the next 30 days most of the time.
Right.
Um, and so I, I'll probably be doing this a lot more. There is so much heterogeneity in this data, to your point, and there's so many different studies, um, that my kind of looking at this, I was like, okay, I can say, what am I gonna do in my practice going forward? I can say, all right, I'll order a CRP or make sure one's gotten in someone in pneumonia and consider steroids if it's elevated greater than 200. Then my next question is, what steroids am I putting them on? Um, there's really nothing I'm all that comfortable with other than what we did for the COVID protocol, which was dexamethasone at my institution, and putting people on 40 pred a day who are actually treating for COPD. And so I don't feel like all that comfortable with the other steroids. I did look at, because you mentioned the Cape Cod trial, I looked at that just to get some thought on like where are we seeing benefit? What are the dosing patterns? And the most, and again, those were very sick patients in this trial, but the most significant benefit was IV hydrocortisone 200 milligrams a day, and they did usually somewhere 4 to 7 days and then tapered, which I don't know. I it's hard for me, and some of this is just mental block, but it's hard for me to think like, okay, I'm gonna be ordering these people's IV steroids unless they look sick. And so I do think that does end up pushing me a little bit more into the camp that you're saying, where if they look big sick and that CRP is over 200, then yeah, I'll do it. I'll give them steroids. If they're not looking like they're giving me a fantastic reason, and that if I can look at them and say, I feel confident you're not dying in the next 30 days, then I'll
Yeah.
say, may I'm not going to give you steroids.
Yeah. Tincture of thyme. It's my third favorite medicine, and I think it's fine to use it.
Yeah. Um, agreed. Agreed. Let's see. Any other thoughts, inputs, insights into either of these studies?
Um, Gosh, I think reaffirming what you know and what you've been doing feels really good. And then in the same, let's see, we've been at this 30 or so minutes now. Also, big question mark going forward. And again, this job is so fun. You got to keep up to date with the things and the literature. And thank God for people like you simplifying it down because it gets complicated, man. It is not
Mhm.
easy to do so. Just appreciate you.
Oh, well, I appreciate you for joining me. And so I would say are my big takeaways from today. So first, when starting an anticoagulation, new start for a patient, pick Apixaban instead of rivaroxaban. They're less likely to bleed and will do just as well from a treating clot standpoint. But if your patient is already on rivaroxaban, doesn't seem from the data there's any good reason to stop them and switch them to Apixaban. And then when it comes to folks with pneumonia, consider getting inflammatory markers if you think your patient might benefit from steroids, because we have seen a statistically significant improvement in mortality with a number needed to treat of 14 if the CRP is greater than 204. Um, so those are big hits. That's all we've got for today. But Dr. Adam Jaffe, it's been an honor and a pleasure, and thank you so much for joining me.
It's been so much fun. I hope I get invited back. Be well out there. Miss you, friend.
All right. Thanks, man. And for our listeners, if there is any new evidence out there that we need to be featuring on the show, and or you are a provider, a specialist, a nurse, a pharmacist, or anyone with value-added insight into the management of the hospitalized patient, reach out to me directly, contact Inpatient Update on social media, or email me at podcast@inpatientupdate.com. And if you find this helpful, then share this around. We got a number needed to treat of 14 for this pneumonia. You share this with 14 other providers, and you've saved a life in 30 days. So please share it if you find it helpful, and it's a joy to do it. So thank you so much for joining me, Dr. Jaffe, and thank you so much for listening to the audience. This has been Inpatient Update.